Hello, everyone, and welcome. Thank you for joining us for today's webinar, Navigating a Terminal Diagnosis, Understanding Patients' Options, presented by Compassion and Choices and hosted by the American Society on Aging. We will begin shortly, but before we do, a few housekeeping notes. I would like to direct you to the left side of your screen where you will see 5 tabs labeled Speaker Bio, Important Information on Group Viewing, CE application here, FAQ/troubleshoot, and event resources. The slides for today's presentation are available for download under the tab labeled Event Resources. You'll find information on how to obtain CE credits for this event under the CE application here tab, including links to the application and to the step-by-step CE guidance webpage. We have changed our CE application process, so please be sure to review our step-by-step CE guidance webpage before you submit your application. Now, this is important, so please listen up. You will be able to access the CE application after a minimum of 2 hours after viewing the event, once attendance is received and recorded, although it may take up to 24 hours, so we appreciate your patience. If you are not logged into the webinar directly using the email address you registered with, then you will not be eligible for CE credit as we have no way of tracking your online attendance. If you registered before the live webinar, you will also receive a follow-up email by the end of the business day that will direct you on how to claim CEs and include links to today's slides and recording. You have 60 days from the live event date to complete a continuing education application. If you have any questions during today's presentation regarding the webinar, you can send those to us at any time using the Ask a Question box, and we will do our best to get those questions in the last few minutes of today's programming. And now I would like to welcome our presenter, Susan Wilhoit, MD, who is a National Medical Director for Compassion and Choices. She is a family physician board certified in hospice and palliative care. Dr. Wilhoit hopes that all of her patients live their lives in ways that are meaningful to them, and does her best to ensure that their deaths are also full of meaning, authenticity, and peace. We are so excited to have you here with us today, Susan.
Thank you so much. Thank you. All right, I wanted to thank everyone for being here and taking the time to understand your patient's options. I think there's a lot that medicine does incredibly well, and I'm honored to be a physician and grateful to get to work with my patients and their families. I think an area in medicine that we could spend a little more time in as a whole is talking about death and understanding what death means to us as individuals. And throughout all of this, throughout this presentation today, we'll definitely be taking little pauses to think about our own humanity and to think about what it is that we bring to our patients who are facing this final phase of life. I want to introduce Compassion and Choices. We're the oldest, largest, and most active national nonprofit organization, and we're dedicated exclusively to improving care and expanding individuals' options at the end of life. In our time together today, I hope we can sit back and consider our patients' perspectives, explore their options, identify our role as clinicians, and we'll kind of identify some key aspects of the voluntary stopping of eating and drinking, medical aid in dying, and palliative sedation. I'd like to begin today by telling you a story about a gentleman I just recently met. I was actually a float physician, meaning I was kind of serving as a primary care doc for a clinic nearby. And this is a gentleman I'd never met before. When the team at the clinic saw that he was on the schedule, you could kind of feel some tension in the room. I think historically he'd been maybe someone that was challenging for people, maybe seen as a curmudgeon. And he came in after not being seen for about 5 months. And unfortunately, during that time, he had about a 60-pound unintentional weight loss. And the health coach, who knew him very well, relayed to me that, she'd really noticed a big change in him. That he was looked a lot weaker, he was paler, he wasn't as how did she put it, as aggressive, I think is how she put it, as he normally is. And so we were just seeing him for a routine follow-up, and I'm not his primary care doctor. I'm normally a palliative medicine doctor, but that day I was serving as a primary care physician. And given his overall symptoms and the whole presentation that I was seeing, knowing that he told us that for months now he'd been having worse and worse swallowing function. I was really concerned about some sort of maybe head and neck cancer that was going on, which may explain a lot of his deterioration. With his permission, I asked if I could tell him what my concerns were, and he was open to that. And I relayed that I was concerned that maybe there was perhaps an underlying cancer as part of our differential diagnosis. And he actually took a deep breath and said, "That's what I think too," because his brother had actually died of a head and neck cancer and had a very similar course, and he was noting that for himself. And he immediately said, "I don't want to go to the hospital. I don't want to do any more tests. I don't want to do any of this." And I saw that little bit of aggression maybe that the health coach had warned me about. And I just listened, and I had him explain to me what his wishes were, what his hopes were. And I realized I was very quickly transitioning from my primary care role that day back into my palliative care roots. And I gave him permission to say, you don't have to do any of these things. You don't have to go do more tests. You don't have to go back to the hospital. He was 94. He had lots of other comorbidities, and he was done. And for him, the idea that this was maybe a cancer was actually a relief. So we really got to talk about what his options were around what death could look like for him. And he left our visit with, I hope it certainly felt that way to me, a sense of peace and a sense of satisfaction, knowing that he had a choice in all of this. And what mattered to him was what was going to guide the care that he would later receive. I later learned from the health coach that he did choose not to undergo any sort of workup, and he later enrolled in hospice care and had a really meaningful family meeting with his son, from whom he had been estranged. And my understanding is that he had a very peaceful death. So I share that story, this gentleman's story, because I think patients are used to what I call the conveyor belt of medicine, meaning that we always are kind of do. And I sometimes tell people, maybe we need to take a break and think not about what we can do to you, but instead think about what can we do for you. And for this gentleman, what we were able to offer was listening, validation of his needs, information around what this could be, and ultimately, we allowed him to be the guide of his path. And that's what I want for all of our patients. I also had an interesting conversation that I later became a part of. The two emergency medicine colleagues are actually friends of mine, and they were talking about medical aid in dying specifically, and how they had a friend, another friend they worked with, went to visit his father, who lived in a state where that was legal. His father, this person's father, chose to use that, and they couldn't believe that was allowed. And what they didn't know is that as two physicians in the state of Colorado, medical aid in dying is also allowed here in this state. And so these are two really brilliant docs and friends that, despite being here at a state that actually allows medical aid in dying, they themselves did not know that that was an option for patients. And the last person I walked with, an old colleague the other day, a former colleague, and she was telling me about a patient that had a cancer diagnosis, that no longer wanted to continue life-sustaining treatments, and instead wanted to stop eating and drinking and allow that to be her cause of death alongside her cancer. And my friend, knowing that I am really passionate about palliative care, asked if I'd ever heard of such a thing, about a patient just stopping eating and drinking. And absolutely, and that voluntary stopping of eating and drinking, VSED, is absolutely a patient's option. And I share both the story of my ER colleagues, my friends, and then my former colleague who I walked with the other day, because these are all physicians who were not aware of their patients' options. Much like the gentleman I shared about before, he wasn't aware of his options. So I really hope that in our talk today, we can take a moment to really think about our role as physicians, thinking about, I'm sorry if that's any better.
Hello, everyone. We are just working on some audio issues here, and we'll be back to the presentation shortly. Thank you for your patience, everyone, as we continue to work through these audio issues, and we will be back to the presentation shortly.
Hello, everyone. I certainly hope everyone can hear me better now, and I appreciate everyone's patience. All right. Yeah, I really just want to empower all of us on this call, on this presentation today, to leave our time together feeling as though you have the information you need to better empower your patients as they face death and dying, and as they consider their options for what their end-of-life care can be. I also want to add that unfortunately, as we know, there are profound inequities in our healthcare system. There are profound inequities at the end of life as well. And so just trying to encourage everyone to be mindful that everyone, regardless of background, deserves a death that is as meaningful as their lives. Let's first talk about our patients' perspectives. What do our patients know about death? What do our patients see on TV? Unfortunately, what we all know, and I think we've all seen different television shows, movies, where CPR is performed on someone who's clearly maybe dead, and moments later they're up and they're talking and they're walking around and everything is fine. The reality is, obviously, that doesn't happen. And so our patients deserve to have information that is meaningful and realistic so that they can make the choices that best honor them. And so in order to combat what our patients see on TV and on movies, we need to offer them information. With our empathy, with compassion, it's our job as clinicians to educate our patients about their disease, help them understand the prognosis, and particularly help them understand the trajectory and how all of these things apply within that individual's unique circumstances, within that person's values, hopes, joys, fears, etc. So before we look at the full menu, if you will, of someone's end-of-life options, I'm going to encourage everybody to go through with all of your patients when you're facing this, helping your patients understand what the benefits are, what the burdens of each option are, and specifically how these options can impact their quality of life, their functional capacity, and their overall prognosis. So here's kind of a not mutually exclusive menu, if you will, of all of our end-of-life options as we face our final phase in life. Certainly patients can pursue life-sustaining treatment. They can say no, they do not want life-sustaining treatment. Maybe they've already chosen life-sustaining treatment. They wanted to discontinue it. Hospice, of course, is vital at this stage in life. And then we'll go into a little bit more detail later about VSED, or the voluntary stopping of eating and drinking, as well as palliative sedation and medical aid in dying. But regardless of which option or options a patient chooses, I want to give a plug here before we begin about palliative care. Because certainly anyone facing a serious or possibly terminal life-limiting illness deserves to have their quality of life enhanced. And that's what palliative care can do. As a specialty field of medicine, palliative medicine physicians are able to focus on a patient and their loved one's quality of life. In palliative medicine, we also do our best to help our patients understand the complexity of their situation so that they can make a well-informed decision. And we also try to enhance our patients' symptom management so that patients are no longer suffering, or at least minimizing suffering from symptoms that could otherwise really impact the person's quality of life. So again, regardless of which option a patient or options a patient may choose for their end-of-life path, it's always important to encourage our patients to seek additional support through palliative medicine. I also want to emphasize that while in this talk we're talking about end-of-life options, palliative care can be offered at any age and at any stage of someone's disease process. So the life-sustaining treatment. I want to believe that this is pretty straightforward, but I've learned from so many patients over the years that they don't necessarily feel empowered to voice to their medical team or to their care team that they don't have to do a life-sustaining treatment option, that just because such options are available, it doesn't mean someone has to do it. So every time that someone's facing a treatment option, or if you will, like an intersection in their care, it's really important that we sit down with them and go through the benefits, the burdens, and how all of this may impact their quality of life. And meanwhile, regardless of whether someone's choosing life-sustaining care or discontinuing treatment altogether, it's always important that we're optimizing and focusing on our individual symptoms, our patient's symptoms. So hospice is a philosophy of care. It's involving a interdisciplinary team of all the folks you see here, many of whom I think are on today's talk and in our webinar today, and thank you all so much for your service. But as a philosophy of care, hospice accepts that death is inevitable, that someone is going to die, and that their end-of-life process should be met with care and comfort and quality of life. So this robust team of people you see from across the discipline, nurses, social workers, spiritual care providers, music therapists, wonderful volunteers, physicians, and CNA who do provide profound dignity care for someone at the end of life. All of these members of the team come together to support a patient and their loved ones as they face their final phase. So I get this question a lot about how does palliative care and hospice differ and where are they similar? A lot of times I even hear a lot of physicians specifically use these terms interchangeably. And I'm going to encourage everyone to not do that. I think certainly palliative care is certainly a huge part of hospice, to manage symptoms, to focus on quality of life. Those are where we really have a great overlap of palliative care and hospice. The difference, though, is that palliative care, as we said before, is for someone during any stage of their process, and specifically is able to be offered alongside curative treatment. So palliative care is intended to enhance quality of life, perhaps while someone is still pursuing ongoing life-sustaining care or curative treatments, if you will. Hospice, on the other hand, is when someone has accepted that they are in their final phase of life, that they no longer want to pursue the quantity of life and instead truly want to focus on their quality of life. They no longer want to return to the hospital. They want the care brought to them. So I encourage patients, especially when they're earlier in their diagnosis, to go ahead and pursue palliative care to support them through their disease-directed care so that they can have better symptom management and more empowerment, more autonomy around what the disease is that they're facing, meaning more information. I think palliative care doctors generally do a really good job of helping patients understand the complexity of their illness. And so having a palliative care physician or team involved in your patient's diagnosis early on can be really helpful in making sure that the patient is guiding the care throughout the path. And then that same team, hopefully, can say, hey, I think we're ready for hospice now. And so having that relationship early in the person's course can really help chart the future path. And so that team can specifically identify when maybe it is appropriate to get hospice involved. I have this list here, and it's not intended, it's intentionally kind of tiny. It's not meant for people to be able to see very well. But the point of this is simply to show that now there are now Medicare guidelines that specifically lay out criteria for various diseases for which someone could qualify for hospice. And the reason I wanted to emphasize this particularly is I think that for a lot of people, hospice sounds like a wonderful opportunity to get great care, and I really believe that it is. And I've heard a lot of physicians offer hospice despite the patient not necessarily being eligible. So I wanted to encourage folks today in our talk to really, before you promise hospice to a patient, please be sure that the individual actually qualifies based on their disease prognosis, trajectory, et cetera. Because I think it gets a real disservice to folks when we offer something and then they later find out that they're not actually eligible. So these hospice eligibility guidelines are offered by Medicare specifically, and then the individual hospice agencies are able to determine on a case-by-case basis whether or not the individual does qualify. Also, some kind of myth busting, if you will, for hospice. A lot of times people think that hospice is a place that you go, when really it's delivered where the person lives. The overwhelming majority of people who are enrolled in hospice and receive hospice care do so in their home or in their facility where they live, as opposed to going somewhere and having to move into a new facility. They actually receive the care in their own environment. Hospice is 100% covered by Medicare Part A. It covers medications related to the person's hospice diagnosis, as well as equipment that the person might need to focus on their comfort in the home. Medicaid, as well as commercial insurances, tend to follow Medicare Part A's guidance around hospice coverage. And so for folks with these opportunities of insurance, they are eligible to receive hospice care and without paying a dime. And then lastly, it's something that I really want to emphasize to all of us, that again, we don't overpromise something. Hospice is not 24/7 care. A lot of times I've worked with patients and families who have been told that, oh, but once hospice is involved, there'll be someone there to take care of mom around the clock. And the reality is that Medicare has established the guideline that an RN or nurse has to visit at least once every 2 weeks. And they recommend that the CNA visits once or twice a week. And then the other members of that interdisciplinary team that we talked about earlier just come as needed, and also based on the individual's preference. So some people say, oh, I don't want a social worker. I don't know why not, because social workers are unbelievably supportive and helpful, but some people say they don't want one, and so they don't have to have one according to the Medicare guidelines. But I do want people to make sure that when we are introducing the idea of hospice or the philosophy of hospice, that we're not offering it as a 24/7 care, that this team is now going to come into your home and move in. I've had lots of patients actually decline hospice involvement because they don't want someone to come and live in their home. And so I think it's really important that we're giving our patients as much information as possible that's accurate, so that they can make a really well-informed decision. So I'm going to just want to make a note here. Palliative sedation, whereas obviously hospice and the voluntary stopping of eating and drinking and medical aid in dying are all patient-driven, palliative sedation is not. So palliative sedation should be physician-led based on someone's symptoms. So it's essentially a nice way of saying refractory symptom management, meaning that if you have a patient, and oftentimes these patients are already enrolled in hospice or are already admitted to the hospital for profound symptom management, if someone has symptoms that are so burdensome and they're not responding to the typical medications despite aggressive medical care, the typical standard of care, then we are able to we are able to actually dose patients on sedating medications to allow them to the point of unconsciousness, so that way they're no longer suffering from that symptom burden. And so the intention of palliative sedation is to aggressively manage someone's symptoms when they otherwise have severe and refractory concerns. This always happens in a monitored or clinical setting, most often in either an inpatient hospice unit or in a hospital setting. And as a result of the sedated medications, complicated by the patient's underlying terminal illness, the patient's likely to die of this combination. So palliative sedation is not medical aid in dying. Palliative sedation is not physician-assisted suicide, and palliative sedation is not euthanasia. Palliative sedation is aggressive symptom management when someone otherwise has symptoms that are refractory or not responding to the typical aggressive symptom care. So the most common reasons why someone would pursue palliative sedation is uncontrolled pain, shortness of breath, delirium, seizures or convulsions. You can also actually use it in a very acute situations, like a massive hemorrhage, asphyxiation, overwhelming pain crisis, or terminal dyspnea, shortness of breath at the end of life. I want to move on now, going back to this more patient-directed care, voluntary stopping of eating and drinking. This is where I was talking to my friend and my former colleague on our walk yesterday, or 2 days ago, when she had a patient that had cancer, and the patient came to her and said, I want to just not eat and drink anymore. I want that to be, I want to speed up my dying because I no longer want to live with this cancer. I no longer am enjoying life. I no longer want to be a burden to my loved ones. And so that individual chose, with the support of her physician and her family, to stop eating and drinking. So by definition, this is a deliberate, self-initiated attempt of an individual to speed up their death, the timing of their death, based on having an otherwise life-limiting illness from which they no longer want to live. In some studies that have been done, mostly a little bit here in Oregon in the United States, but mostly actually in Belgium, here's a list of why a patient may choose voluntary stopping of eating and drinking, otherwise known as VSED. The wish for control. They want to limit their suffering. Some patients will say they're ready. Some patients may not be ready, but their quality of life is such that it's no longer serving them, and they don't want the quantity of life at the expense of the quality of their lives. For some patients, they just want to be able to control the setting of their death. Maybe they want to die at home. And other folks say they've lived a full life. And again, going back to that readiness. So again, the studies that we do have, they're very little data on the prevalence and the demographics around VSED. The Belgian study says about 2 deaths per year, maybe 2,800 deaths annually. Typically, it takes about 10 days, plus or minus 7, depending on the patient's underlying debility, depending on the patient's underlying state of hydration or nutrition, and certainly depending on the otherwise underlying disease, a terminal disease or life-limiting illness from which they're suffering. Most people die within 15 days. So the clinician role in voluntary stopping of eating and drinking, while the patient does not need a permission or the authorization by any physician, it's all patient-driven. It's an incredibly autonomous decision. The physician participation and clinician participation can be really important in the patient's overall success. So it's important that the physician, or any clinician involved, understand that the patient is making this out of full decision-making capacity, that the patient does have the autonomy and is able to demonstrate that they understand what they're undertaking, that they're not being influenced by any sort of behavioral health concerns, and that they understand what the risks and the benefits are, as well as the alternatives. And ultimately, that this is a voluntary decision. I was actually having a conversation with another colleague, a palliative medicine physician, about VSED a few weeks ago, and And you made the excellent point that the VSED as a patient's option for end-of-life care is profoundly voluntary because we tend to have this innate will to live. And if someone has that innate will to live, they're having to fight that will by stopping eating and drinking. And so it would be profoundly unlikely that this could possibly ever be coerced. Certainly it's possible. So I think it's really important that the physician really does a good job of thoroughly assessing for that. But this is just a very biologically voluntary and very willful thing to do that the patient undertakes. And then ultimately, in order for the patient to feel or to be successful, but I also think for the family's sake, so the family doesn't experience or is concerned about the patient who's chosen to do this, who's suffering, it's really important that the physician maintains involvement, and ideally a hospice is involved as well, to monitor and treat symptoms. Because there can be profound thirst associated with this initially. There can be agitation. There can be the typical pain and shortness of breath that folks experience at the end of life. And so having an expert involved to monitor and treat symptoms can really enhance someone's meaningful, peaceful dying process. And I think as important as that is, the physician role, I think I can't say enough about the patient having a supportive care team. So loved ones that are in alignment with the patient's decision, that sees this individual through, that I think it's a very selfless act on the loved one's part, and sometimes a very selfless act on the individual's part. But I think that in order to make this as peaceful and as meaningful as possible, making sure that really important conversations are had so that the patient is at the center, the patient is guiding all of this, and that the care team that's surrounding the patient is there to uplift and align with the patient's values. Moving on to medical aid in dying. So in some places in the United States, this is a legally allowed process in which someone who is terminally ill, meaning they have a prognosis of 6 months or less, and also has the capacity to make medical decisions on their own behalf and has the ability to self-administer, can request a prescription to take a medication and end their life on their own terms. So each jurisdiction where medical aid in dying is legal has very specific requirements. Common to all 11 jurisdictions are these 4 requirements. Must be an adult, so you have to be 18 or older. 2 physicians have to certify, 2 providers, I should say, have to certify that the patient has a prognosis of 6 months or less. The patient has to have the capacity to be able to make decisions on their own, and the patient has to be able to self-administer. So I want to take some time here to really invest in why language matters. Medical aid in dying is not assisted physician suicide or physician-assisted suicide. It's not euthanasia. And specifically, let's look at how do medical aid in dying and euthanasia compare. I think that they have an underlying shared intention in which the patient is asking for a peaceful death. With medical aid in dying, I can't emphasize this enough, the patient self-administers. The patient remains in control. The patient decides when they take the medication. And this is authorized in 11 jurisdictions, 10 states plus the District of Columbia. With euthanasia, someone else is administering the medication. So the patient does not have control. And this is fundamentally illegal throughout the United States. Comparing medical aid in dying to suicide, we know that someone that has who chooses medical aid in dying, they have a terminal diagnosis. They have to have a prognosis of 6 months or less. They have to have the capacity. They're mentally capable. Oftentimes, patients who choose this route use self-preservation and dignity as the reason why this is so valuable to them. It requires a lot of planning, a lot of preparation, and oftentimes loved ones are involved throughout that process with the individual to support the person through the entirety of the process. On the other hand, suicide can be treatable with behavioral health. We can do a lot to support someone who is suffering from suicidality. The person has thoughts that are mentally impaired. They want to hurt themselves, not preserve themselves. And unfortunately, we all know that suicide is often done when someone is alone. It's often a very impulsive act. Throughout all of the jurisdictions where medical aid in dying is allowed, every statute clarifies that this is not suicide. This is not assisted suicide. This is not a mercy killing. This is not homicide. The reasons why patients have reported over the years why they're choosing this, what's driving them to consider medical aid in dying, autonomy, no more suffering. They know this is a trusted practice that has been done for years. They don't want to be a burden. I've had a lot of patients tell me they don't want to be a burden anymore. Again, this idea of self-preservation of their own dignity. And these are folks who really emphasize quality over quantity of life. This is the current regimen. This is an evolving science, absolutely. This is the current regimen that we are recommending. People can take it by mouth, by the NG tube, through a peg, or through the rectal catheter, as long as the person self-administers. When someone is completing a death certificate for a patient who has completed medical aid in dying, it's always the underlying terminal illness that's reported as the cause of death, the natural death. And again, going back to what we read before, this is not suicide. No one is forced to participate in this, and this does not impact someone's health insurance. And recently, the AMA now allows for physicians to support their patients with medical aid in dying. And no topic or no conversation about end-of-life care would be complete without emphasizing the value and the importance of advanced care planning. So whether or not your patient has a life-limiting illness or doesn't, it's always important that we have a healthcare directive, because we need the patient's voice to guide and direct our care if there's ever a time when the patient's not able to speak for themselves. So it's so important that, particularly for folks who are in the later stages of life or otherwise have a life-limiting illness, to talk with their family, talk with their providers, emphasize what they value, share what they love, share how they want their time spent, and then most importantly, document. Document. In fact, I oftentimes encourage patients to not only document after a thorough conversation with their physicians, but I also encourage patients to actually make a video of themselves speaking to their loved ones about what their wishes are, so that if there's ever a time where they're not able to communicate or articulate their wishes to their loved ones, the loved ones can then go to that video and hear from the mouth of that individual in their own words what matters to them, what their values are, and how they want their care directed. So please, if your patient ever mentions anything about their advanced care plans, please offer them a really robust, thorough, thoughtful conversation so that they can make these choices with the information that's necessary relative to their unique circumstances, relative to their medical conditions, and relative to their values. I think both are equally important and both play a role in how someone approaches these decisions. I'm just going to say one plug real quick for anyone out there who has the authority to sign these documents. Please don't ever sign one without a conversation with your patients. That does happen sometimes, and unfortunately what we see is often a very confusing picture at the end of life. And so I want to make sure that these forms are completed with a meaningful, thoughtful, person-centered conversation. So for everybody on the call today, I know you guys are going to be able to download the slides. And so once you have downloaded these slides, you'll actually be able to click on any of these links here that can go into a little bit more detail about all of these topics. And I encourage you to do so. There's some great resources here that you can share with your patients and share with your colleagues, so that we can spread the word about how important it is to talk about our patients' end-of-life options, so that we can empower our patients to really choose the care that best advocates and supports their wishes. If there are any clinicians, too, that just need some support in talking through what their patients' options could be, you are welcome to contact our doc-to-doc service with Compassion and Choices. You can email us here. You can also give us a phone call. We have 2 physicians that staff this line, and we are dedicated to helping other clinicians help their patients. And so whether it's just talking through a complex advanced care planning patient, or talking about what it would look like to pursue VSED or medical aid in dying with a person, we are here to support you in supporting your patients. Another excellent resource specifically for medical aid in dying is the American Clinicians Academy on medical aid in dying. There's some excellent tools there, both for physicians and for patients. I want to thank all of you for taking the time today to sit down and learn about what your patient's options are. And I know that by you being on this call, you are already an advocate for your patients. And I think that when a person, an individual, feels that someone in healthcare is advocating for them, you are allowing them to feel heard. You're allowing them to feel seen. And that is more important sometimes maybe than any of the actual medical treatments we can give them. So thank you for taking the time to advocate for your patients. Thank you for taking the time to acquire some information, or maybe this is just the beginning. If you have more questions, please reach out to us. We are so honored at Compassion and Choices to be a part of your patient's care, and thank you so much for supporting us. I'm going to go ahead and ask Victoria if we have any questions today.
Thank you so much for that presentation, Dr. Wilhoit. Such important and valuable information that you have provided today, so thank you so much for that. We do have a few questions here, the first of which is regarding the person who did not want a workup on his symptoms.
Yeah.
It seems there can be an obstacle to being accepted into hospice care in the absence of a diagnosis. Can you comment on that?
Yes, and that's an excellent point. It's something we see all the time. I think it's a very case-by-case scenario. Absolutely, especially with that one slide with all the different very specific Medicare guidelines for hospice eligibility. I would say that in that particular person's case, in that gentleman's case, he had multiple comorbidities and really what we call in hospice care, painting the picture. So if you looked at his recent history in the context of his multiple comorbidities, it seemed very consistent, and plus his family history, I should say, it seemed quite consistent with a likely an underlying cancer. And so hospice was able to say, hey, based on this big picture, painting the picture, without forcing him to undergo diagnostics, we were able to get him into a hospice that was able to serve him. That's an excellent point, and that can happen a lot. Absolutely. So I think it's really important to paint the picture, and specifically not just the medical complexity of the person's picture, but also the person's philosophy, or where that person is in terms of their values, meaning that if this point the person really does value being at home, not returning to the hospital, having care come to them, that's a really important thing to include in your initial request for hospice evaluation.
I think that's great to know, not just that obviously you need some evidence, some medical evidence to substantiate the need, but that you don't have to force the person to undergo all of this testing, which can be strenuous and exhausting physically and mentally for them, so that's great to know. Another question is, can palliative sedation be used in a nursing home setting that is restraint-free, or is it considered a chemical restraint?
That's a great question. And I would say that I've never seen it done in a nursing home, and that's more, I think the reasons why I haven't seen it done in a nursing home is I do think it requires more medical oversight than what the nursing home is able to provide. So oftentimes when I've seen it done, it's in either an intensive care unit or some sort of a step-down unit, if you will. So kind of a step down from not a routine floor in the hospital, but not the ICU, so it's somewhere in between. We call it a step-down unit or a progressive care unit, if you will. So I typically see them in one of those two settings, either the progressive care unit or the intensive care unit, or like I said earlier, in the in the inpatient hospice setting. So I think that in a nursing home setting, because of the intensity that's required to monitor and manage the medications, they're all infusions. I would not imagine it being done in a nursing home. I've never heard it referred to as a chemical restraint or any of the medications, but I would say that I could see how some nursing homes may interpret it that way, but I think that alone wouldn't be the reason why they wouldn't allow for it in a nursing home. I think it's just the acuity of care that's required would be very difficult to manage in a typical nursing home setting.
Thank you. We also have, can a person who has MS, multiple sclerosis, make this type of decision with their doctor? And I'm guessing that depends.
Yeah, that's a great question. And absolutely, I think I'm not really sure. And if the questioner wants to kind of elaborate a little bit, would you say this decision? Absolutely, multiple sclerosis is certainly a life-limiting illness that patients deserve a lot of support around decision-making. And so I would really encourage anyone with MS to have conversations early with their care teams and with their families, with their loved ones, about at what point would they want to start having these conversations about end-of-life care, and at what point or what types of end-of-life care would most align with their values. So I think it's really important. And again, I really advocate for having these conversations early in anyone's process and often, meaning that these decisions and someone's choices can change as their disease trajectory changes. So throughout the course of someone's progressive illness, I would absolutely encourage more conversations, not just like a one and done. I think that people really deserve to be met where they are on their own path, throughout their path, so that when it comes time to really implementing the choices, we have the patient's most up-to-date and most thought-out options.
Okay, great. I have a couple of questions that seem to be connected here. So how can the patient or a patient that has dementia have the capacity to decide on medical-assisted dying? Do they have that capacity?
Yeah, that's a really great question. And so because medical aid in dying emphasizes without doubt, without question, the individual's capacity to make decisions on their own, patients that have dementia and in the terminal stages of dementia would not qualify for medical aid in dying. Certainly, I've had a lot of patients say to me very early, or even patients who maybe have mild cognitive impairment and are thinking about, what if this becomes dementia? I would like to be able to use medical aid in dying. And the reality is that because medical aid in dying mandates that the patient must have the capacity at the time to be able to self-administer, that patients who are dying from terminal dementia specifically are not going to be able to access medical aid in dying.
So that, I think, kind of leads into this next question, and I think you kind of answered it because of the self-administration portion of it, which is what differentiates medical aid in dying from assisted suicide and euthanasia. But this question is, can the patient's medical proxy ever make the decision if the patient and their proxy discussed beforehand? Is there a legal or signed document for this?
That's a great question, and the short answer is no. That the proxy, specifically if the question is about medical aid in dying, the answer is no. So that always has to be individually requested. I didn't go into all the different requirements with medical aid in dying, but some of the requirements include verbal requests by the individual, written requests by the individual, all throughout which the person has to have the capacity to demonstrate, must be able to demonstrate the capacity to be making these requests on their own behalf. So it cannot be through proxy, even if someone were to write out beautiful documentation and have it notarized about what their wishes were, and if they had a supportive proxy, the proxy is not able to act on the patient's behalf in that way.
And what about for palliative care or
Oh, for
hospice care?
palliative.
That would be something
Yeah.
different.
Yeah, absolutely. That's a great differentiation, actually. So absolutely. So if outside of medical aid in dying, the proxy or the surrogate decision maker, the medical power of attorney, can act on the patient's behalf to pursue hospice care, to have goals of care conversations, and to really help direct the patient's care in accordance with or in alignment with the patient's previously stated wishes. Something that I always emphasize to patients and to families, and actually to physicians, to be honest, that the proxy is never to make a decision for themselves. They're always supposed to be making a decision that they believe the patient would be making if the patient were there. So I always will tell families, if I have a patient who's not able to articulate their wishes, I'll ask families to, especially in the hospital setting, I'll say, hey, if let's say we're all sitting around the patient's bed, we're at the bedside, and the patient's clearly at the center, but the patient's not able to participate in the conversation, I'll ask the family or ask the loved ones, hey, if so-and-so could be sitting right here with us and seeing what we're seeing and hearing what we're hearing from the other doctors, what would this person tell us to do now? So really trying to make it as clear as possible that we don't want the surrogates or the proxies to make the choices that they would be making for themselves, but rather they are simply instrument of the individual's will, the patient's will. And I'm hopeful that whenever someone assigns someone else as their power of attorney, medical power of attorney, that they're doing so trusting that that individual is going to uphold their voice, because at the end, that's really what should matter, is that it's still the individual's wishes through the voice, if you will, of their surrogate.
Absolutely. Kind of in that same vein, can the desire for VSED be added to the PULSE form if someone reaches a certain point in their disease, so that if they are no longer alert and oriented, their wishes can still be honored? And for those of us that don't know, i.e. me, can you elaborate on what the PULSE form is as well?
Oh, absolutely. Thank you for asking that. I'll do that one first, the PULSE. So PULSE, or most, depending on where you live. Here in Colorado, it's the MOST. It's MOST. So it's the medical order for scope of treatment, and it's the physician order for life-sustaining care. Is the other one that's PULSE. So it's the physician order that is signed both by a provider and the patient, and should be a reflection of the patient's wishes in very specific medical circumstances. And so typically, a PULSE or MOST is going to have 3 sections. The first is about CPR. So in the event that a person has no heartbeat and simultaneously has no lung function. So they are not breathing and their heart is not beating and they are dead. And so that's how I actually will sometimes describe it to people, that if you are dead, your heart is not beating, your lungs are not breathing, you have the option for the attempt of resuscitation, or you can say, if I'm dead, let me stay dead. And in that case, we can say, allow for a natural death. So that first section of the form is going to be CPR, yes or no. It's essentially what other people refer to as a DNR, but the first section alone is just that do not resuscitate or do not attempt resuscitation, otherwise known as the request for a natural death, meaning that when someone says, if I'm dead, my lungs are not breathing, my heart is not beating, let me stay dead. So that's the first section, and that's a bit more cut and dry. The second section goes through actual medical treatments, and so it has 3 different levels of medical treatments. The first is what we consider like full aggressive care, in which the patient is saying, yes, extend my life by all means medically effective. So that means put me on life support, put me in the ICU, put me on whatever machines or drips, anything you need to do to keep my physical body going. That is what we consider kind of full aggressive care. The next one underneath that typically is what we call selective care. So that's for somebody who says, hey, look, if I'm really sick, and you need to give me some IV antibiotics, or you need to take me to the hospital, maybe you need to put me on some non-invasive breathing support, so like a BiPAP machine, for example. Yes, those folks want life-sustaining care to a limit, to a certain, there's like a ceiling where they say, I don't want to be in the intensive care unit. I don't want to be with invasive ventilation. I don't want the breathing tube put into my mouth. I don't want, again, to be put into the intensive care unit. But if you think I need some IV antibiotics, you think I might need some, some non-invasive breathing support, yes, that's okay. That's selective care. And then the last of the three options in that second section is comfort care. And that in that case, someone would say, I do not want to go to the hospital. I want the care brought to me. I want all of the care that I receive to be focused on my comfort. I no longer want IV antibiotics. I no longer want any sort of invasive or non-invasive breathing support. I accept that this is my final phase of life, and I want all of the care that I receive to be focused on my comfort. And I always encourage folks to consider that as an option when they have the support of a hospice team, because one of the benefits of hospice, and I could have said this earlier, is that if someone does suffer some sort of medical emergency at home and they're enrolled in hospice and they don't want to go to the hospital, rather than calling 911, they can call their hospice care team, and those folks can actually guide them through the process. They'll come out and evaluate. If the person needs to be seen at the inpatient unit, that can happen. But it really skips the typical conveyor belt, again, of medicine, of calling 911, getting the ambulance, going to the emergency room, getting admitted, getting tests, et cetera, et cetera, et cetera, and instead allows the patient to stay where they are, have the care come to them. And that's really that comfort-focused care for people who truly have accepted their final phase of life and really want to focus all of their care on their quality and comfort. In most of these forms, there's a line in that section called additional orders. I always encourage my patients to consider what else can we do to make this form more authentically you? What else can we write on here to really elevate your voice? And so for a lot of my patients who are not ready to choose comfort-focused care, but they know they don't want to be put on a ventilator, for example, they know they don't want to be in the ICU, they'll select the middle one, which is that selective treatment, and then they'll ask me to write in that additional order that if the patient's condition is reversible, okay, they're okay with this selective level of care. But if the person's course is appearing to be irreversible or a meaningful recovery is not likely, at that point consider transition to comfort. And that allows for the person to say, hey, yeah, try these things, but if it's clear that I'm not going to get better and I'm not going to have a meaningful recovery, at that point, please transition to comfort. And so it's kind of like when we write words like that, orders like that on the MOST form, we're able to, or PULSE for that matter, across the country, we're able to really tailor it to that individual to make sure that in that sort of circumstance, that we're not just pursuing the care if it's not aligned with who this person is and what they want. And it really, I think, my hope at least, is that it reinforces that this person doesn't want to be alive just on machines and just to be alive, but really does want to try certain medical interventions, but also wants to be allowed to transition to comfort if that's where they are. And then the third section on all of these forms is about artificial nutrition. And so patients have three options. They can say absolutely no artificial nutrition by feeding tube. That means feeding tubes. And so you can say, nope, not at all, definitely don't want it. Or they can have an option to say a short-term, if it's a temporary thing, they can do a short-term feeding tube, or they can do a long-term permanently placed feeding tube. And again, going back to that additional orders, patients will say, well, I can help patients write as an additional order. If a meaningful recovery is likely and artificial nutrition is going to support a patient towards a meaningful recovery, then yes. Otherwise, no. And so I know I have 1 minute left. That's the most in the PULSE forms. And then the other part of that question is typically being able to direct VSED for somebody who doesn't have capacity really varies case by case, and it's not something that's commonly seen. The state of New York does have kind of a nuanced advanced directive that you can look into about VSED directed by proxy, but it's really something that I've never seen done. And speaking with my VSED colleagues recently, it's not something that we really do. So I hate to end so abruptly. Victoria, are there any other questions?
Well, we do have more questions, so we're kind of
I'm sorry.
running out of time here.
Yes,
If
I'm
it's
so
okay with
sorry.
you, I can send some of these questions over to you so that we can
Yeah,
get them answered.
absolutely.
So
Perfect.
there are some good questions here,
Oh,
but
great.
thank you so much. Like I said, this is such valuable information and something that's not talked about nearly enough.
Yeah. Hmm.
And so it really has been such a pleasure having you today, and we want to
Thank
thank
you.
Compassion and Choices for bringing this webinar to our audience. Please be sure to check out upcoming webinars at www.asaging.org, including a physician's perspective on medical aid in dying, advanced care planning, education, empowerment, and advocacy, and the role of doulas at end of life, all presented by Compassion and Choices. As a reminder, our CE application process has changed, so please do review the CE guidance webpage that's linked in the CE application here tab and in your follow-up emails, as well as the webinars page. You will not be able to access the CE application until a minimum of 2 hours after viewing the event, although it may take a little longer for larger audiences. If you see a message that you have not attended when you did, it is because the attendance data still needs more time to sync, so please try back a little later. If you have any questions about the webinar, please feel free to email asa@info@asaging.org. You can also go to our website to see upcoming webinars. Like I said, Compassion and Choices has 3 more webinars coming up regarding end-of-life care, so please do check those out. And if you would like to share today's presentation with anyone, the CEs are available for a full 60 days. Thank you again, Dr. Wilhoit. Thank you, Compassion and
Hmm.
Choices, and we hope you will all join us again soon.
Thank you all so much. Thank you, Victoria.
All right. Bye-bye.
Bye-bye.